So today my talk is going to be about, my voice clear for everyone?
Yes.
Okay. So my talk is going to be about managing trauma patients, okay? And we'll focus more on massively bleeding because they are more challenging. There are lots of controversies, a lot of updates, and a total change in the mindset of how we manage bleeding patients, as you're going to see. So this is my outline. I'm going to be talking about the definition of massive bleeding, why do they bleed, how does it happen, and we'll go through the main 4 pillars of resuscitation, how can we treat these patients, and what our goals during and after, what are our endpoints for the resuscitation. And we'll talk a little bit about damage control resuscitation, but my colleague Dr. Nasser will talk more about it, inshallah. So why did we choose this topic? As we all know, hemorrhage is the commonest preventable cause of death, especially in the first hour when they reach to the hospital. And unfortunately, if things don't go in the right way, if you don't treat these patients, pick them up early first and treat them in a fast, systematic way, most of them can even lead to death in OT. So it's a very important topic. So the definition of massive bleed, these are all old definitions, I'm sure most of you know it. The most practical one, which I feel is, you will keep it in mind when you see a trauma patient. So when your patient starts to require more than 10 units of packed red blood cells in the first 24 hours, or to be more precise, 3 to 5 units in the first 5 to 6 hours, you're going to say, okay, my patient now is going to massive bleed. I need to focus on this patient. Now, this diagram shows you that the commonest cause of in-hospital death in trauma patients is from exsanguination or coagulopathy or uncontrolled bleeding. That's why we're going to talk about it in more detail. The second commonest cause is CNS injury, and the third cause is multi-organ failure. So we need to keep in mind that not all bleeding patients are the same. There are basically 2 main categories. So there's the mechanical bleed, which is bleeding from a tear in one of the major vessels, and that can be only fixed surgically. So no matter how much blood you give, if you don't take your patient to the OT as soon as possible, you're just going to be wasting your time and resources and effort. The second type is the coagulopathic bleed. Now this is the type that we're going to be talking more about. So why do patients bleed? Until this publication in 2003 by Karim Brogan, we used to think that patients bleed because of what we do. So it's iatrogenic. So it's because of what we give. So we give a lot of fluids, especially in the First World War, Second World War. We used to just give them huge amounts of fluid before getting the blood. So we discovered that fluid is harmful because fluid will cause dilutional coagulopathy, the clotting factors will be decreased. The fluid is cold, so you're going to get your patient more hypothermic, it could be already hypothermic. And sometimes if you use large amount of normal saline, you're going to get your patient to hyperthermic metabolic acidosis. So, and on top of that, he's already in shock, he's already acidotic, so you're getting him more acidotic. And then they will go into the lethal triad, as we all know, hypothermia, acidosis, and coagulopathy. So they're going to just continue to bleed and bleed more. But then after 2003, Karim Brogan and his colleagues, they discovered that these patients are actually coagulopathic from the beginning. So there's an endogenous cause. And actually 25% already reach to your hospital, they're already coagulopathic. And once you see these patients, their mortality is surprisingly very high, up to 8 times higher. So if you pick these patients early and treat them early in a proper way, that would save their lives. So what happens? So this is a new term. So this is called trauma-induced coagulopathy or acute coagulopathy of trauma. So basically, the trauma itself, it causes tissue injury, of course, and it causes hypoxia. So from the shock to hyperfusion. So these 2 main causes will lead to endothelial dysfunction. And then when you get into dysfunction, there will be a get a lot of mediators released. So one of these mediators activated protein C, and that will decrease your thrombin generation. You also have increased TPA, and that will increase your fibrinolysis. And the direct tissue injury itself will cause platelet dysfunction. So the higher the injury severity score, the more likely these patients would be coagulopathic. Okay? So that's why it's very important. You need to know exactly where your patient lies in. Does my patient need platelets, or does he need FFP? And how much? Okay? So usually we start with blood resuscitation. We don't have time. We need to give blood immediately, activate the massive transfusion protocol. But then you have to switch to targeted management and early diagnosis. Because you don't want to end up giving the wrong product or the wrong amount to your wrong patient at the wrong time. So for example, if this patient needs 6 units of platelets, you might be giving FFP, for example, or you might be giving only 2 units of platelets, okay? So these are the 4 main pillars for goals of trauma resuscitation, okay? First of all, of course, you have to control the bleed. So you have to look for the source of bleeding. Where is my patient bleeding from? So it's very important to go in a methodological way, start from head to toe, so you don't miss any point, okay? And it has to be, of course, very, very fast. Try to control it before taking the patient to the OT. So, for example, if there's an external bleed, source of bleed, just apply a tourniquet. If there's a massive hemothorax, get a chest tubing as soon as possible. You might even consider angioembolization or REBOA, which is resuscitative endovascular balloon occlusion of the aorta. Okay. The second point is minimize iatrogenic injury. So what we discussed now about fluid, try to minimize fluid, and on the contrary, try to start blood early. Okay. So minimizing crystalloid, vasopressors, try to be very, very cautious with that, because we're going to talk about that later. And then maybe you can even consider permissive hypotension. The third one is restoring perfusion. So make sure your patients are hypoperfused. So give them adequate volume, activate the massive transfusion protocol as soon as possible, and consider starting one-to-one transfusion. The last one is promote hemostasis. So these are the adjuncts. So you can consider using early tranexamic, cryo, 4-factor PCC, and we'll talk a little bit about rotin. So this is what we mentioned earlier, stop the bleed. So look for the source of bleed and either apply pressure, pelvic binder, wound packing, whatever will just help to buy time. Now, the second point is permissive hypotension. A lot of studies looked at this. Before, we used to try to normalize the hypotension, like keep the blood pressure 110 systolic or MAP of 65. But then we discovered that this is actually harmful, especially in penetrating injuries. Patients who still you didn't control their bleeding. When you increase their blood pressure, that's going to actually dislodge the clot and cause more bleeding, and then you're just going to go into a vicious circle. So they came out with these recommendations. You don't have to be very strict with. Of course, at the end, we're not treating numbers. Treat the patient as a whole, but keep this in mind. So for penetrating injuries, if your patient is healthy and fit, you can accept 60 to 70 of systolic blood pressure. But this should be, keep in mind, this should be something transient, because you don't want your patient to be in shock for a very long time until the patient is taken to the OT. Then you can keep the blood pressure higher. In blunt injury, you can keep it around 80 to 90 of systolic. But in traumatic brain injury, we cannot apply this because you need to maintain the cerebral perfusion pressure. As you all know, we need to avoid secondary brain injury, and that is through keeping the cerebral perfusion pressure of 60. So that's why you need to keep the MAP of 80. So it's not applied. And this is one of the studies which looked into that, published in Journal of Trauma. They compared hypotensive resuscitation, so this means maintaining the systolic blood pressure of 70 versus normotensive, which is systolic 100. They actually found that the hypotensive resuscitation reduced the bleeding, it reduced the clot wash-off, it minimized the dilution of factor and platelets, so it minimized even your need for transfusion, and it minimized hypothermia. And there was no difference in mortality. So, the next point This study was published in 1994, New England Journal of Medicine. They compared immediate versus delayed fluid resuscitation. So once the patient comes, they're divided into two groups. One group, they immediately give them fluid, around 1 liter, and the other group, they wait till the bleeding is controlled, and then they give them fluid, and it's also very, very minimal, like around 100 ml. And they actually found the survival rate is higher in the delayed group. Okay, so it was 70% compared to 62%. So that's why they recommended now that always avoid giving excess fluid and wait till the bleeding is controlled. This shows you the lethal triad that we talked about. Acidosis, hypothermia, coagulopathy. So always keep this in mind. Make sure your patient is not acidotic, and he's not hypothermic, and not coagulopathic. So one of the things that promotes this is fluid. So that's why they even found that fluid can cause reperfusion injury. If you give a large amount, it will increase their leukocyte and inflammation. It will promote SIRS, ARDS, multi-organ failure, and even compartment syndrome. Okay, and this is the vicious circle that I talked about. So you give them fluid, they bleed more, they go into hypotensive, and so on. Now, what about vasopressors? Vasopressors, people don't like to use because, as we said, these patients are already in shock. If you start with vasopressors, you're going to worsen it. Okay. And you always need to keep in mind about the phase of the physiology of hemorrhagic shock. What happens exactly? So in the first phase, they of course go into a sympathetic excitatory phase with all the catecholamine surge. Their stroke volume will be low, their heart will be tachycardic, and they will be in a vasoconstrictor state. Later on, when the catecholamines get depleted, and also the artery vasopressin gets depleted, they will go to the sympathoinhibitory phase. So their heart rate will go down, sympathic rate will go down, and they will be vasodilated. I put this here because I want to show you that if you start your vasopressors in the early phase, in the vasoconstrictive phase, that would be actually harmful. So if you really need to use it, at least wait a couple of hours and then try to use a very small dose. So what's the role of vasopressors in trauma? It's just as a bridge or just to buy time. So you want to avoid giving this patient a lot of fluid, but you want the BP to still be maintained. So just start with a very small dose of vasopressor till you take your patient to the OT. I think one of maybe the only vasopressor which was mentioned that it's the safest one of them is vasopressin. And this was the Avert shock trial published in JAMA 2019. It was a single center, level 1 trauma. They include patients who required more than 6 units of blood within 12 hours of injury. And they actually found that when you start a low dose of vasopressin, it decreased your transfusion requirements up to 1.5 liters, which was really impressive. Now moving on to restore perfusion. This is the proper trial, it's a famous trial. So they looked at comparing 1:1:1 ratio, so giving plasma, platelet, RBC in an equal ratio versus 1:1:2. So people used to think that if you give more packed RBCs, that would be better, but they found out that there was no significant difference in the 30-day mortality, and on the contrary, the 1:1:1 ratio had even reduced mortality from bleeding. And they also found out that every 500 ml of crystalloid that you give, especially in the first 6 hours, will increase your ARDS up to 9%. So, massive transfusion protocol.
5 minutes, please.
How many?
5 minutes.
So, massive transfusion protocol, it's very important. You need to make sure that your institution has one, because it actually showed that it improved the mortality significantly. And why is that? Because when you have your protocol, you're going to give blood early, you're going to improve the blood bank efficiency, you're going to decrease your blood products which are being used and avoid excess fluid. And they found that each minute delay in the massive transfusion protocol activation was actually associated with an increase in mortality by 5%. There are lots of scores. So stable and a positive fast. So any two of these, you will activate your MTP. And the MTS is actually more sensitive. So they added the base deficit. If you have a base deficit more than -6, INR more than 1.5, hemoglobin less than 11, then you need to activate your massive transfusion protocol. Now, what about monitoring? We have the traditional coagulation test, which is INR, PT, PTT. That's not really accurate. It gives you a general overview, but it doesn't tell you exactly which product do I need to give. Do I need to give cryo? Do I need to give FFP? How will I know? So they came up with this, the viscoelastic monitoring, which is the ROTAM or the TEC. And this is how it looks. I think they use it mainly in the OT, the liver transplant, cardiac surgeries. But I hope that we will be using it more and more, especially in the ER and the ICU. So this is how it looks like, which will give you a graph, okay? Starting by the clot formation, and then the clot initiation, till you reach the maximum amplitude, and then you get the fibrinolysis. So you have the R time. The R time gives you an idea about the clotting factor. So if you have a prolonged R time, you need to give them FFP. If you have a prolonged K time, you need to give them cryo, and so on. And this is an example of the different shapes of the TEC. So you have that the first one is the normal one, and then, for example, the second one, you have a really prolonged R time. Okay? So it gives you a rough idea about what your patient actually needs. And this is one of the protocols which actually they involve the ROTAM. From the moment the patient comes, they get a baseline ROTAM, baseline APG, okay? And then they check it every 10 minutes and reassess, reevaluate, because every 10 minutes or 15 minutes the patient will change. So this study was published in Scandinavian Journal of Trauma. It looked at ROTAM because people were starting to question, okay, how useful is it? How applicable is it? So it was really, really found to be useful. It predicts your need for massive transfusion. It tells you when you need to activate the MTP. It's prognostic, so it tells you about your mortality, especially if you have prolonged fibrinolysis. That is associated with a high mortality. Also, this study, the iTactic, it was published in Intensive Care Medicine in 2021. They specifically looked at patients with traumatic brain injury. And they also noticed that when you use ROTAM, you're going to avoid giving them unnecessary blood products. And actually, some of the guidelines now, they do recommend, it's a grade 1B recommendation. This is the European guideline for managing trauma patients. Damage control resuscitation, it was developed to work synergistically with the damage control surgery. So before you take the patient to the OT, start to implement the targets for the damage control resuscitation. So as we said, minimize fluid, start blood early, early hemorrhage control, and permissive hypertension. And it was actually found to improve mortality significantly. This is also the heme resuscitation cycle, same concept. And then the tranexamic acid. So tranexamic was looked at in two popular trials, in CRASH 2 and CRASH 3. So CRASH 2, they involved 20,000 patients, and they compared giving a tranexamic, especially in the first 3 hours versus placebo, and they found that actually decreased the mortality significantly.
1 minute, please.
And this one, the CRASH 3, looked at head injury patients. They found it was useful in patients who had mild but not severe head injury. So your endpoints, temperature, urine output, the hemodynamic, but the most important is the base deficit and the lactate, serial lactate levels. So they looked at serial lactate, and they found that patients who had a higher time to clear the lactate, they had a higher mortality. And also the base deficit is very important. So base deficit less than -6. This was published in 2010. It showed that these patients had increased risk of hypertension, increased risk of going to the OT to control their bleed, and increased mortality. So any patient you face who comes with already hypertensive, with a base deficit less than -6, and a positive fast, try to take them to the OT as soon as possible. Okay, so this is the last slide. It's just a summary of all what we said. So the basic 3 things: hemorrhage control, volume Thank you so much.
Now it's my pleasure to introduce the next speaker,